So this is a frontal X-ray shoulder, right shoulder of an adult female patient. So I can see multiple rounded opacities of variable sizes with well corticated around the humeral head and within the in the intracapsular region, probably. Also around the they're projecting over the acromion and around the acromioclavicular joint. So these findings are suggestive of synovial osteochondromatosis, and since they appear to be of uniform size, so I'm suspecting primary synovial osteochondromatosis.
Right.
So, and no other aggressive lesion noted, no periosteal reaction or soft tissue abnormalities seen in the provided image.
So you said primary synovial osteochondromatosis because they are all of uniform size, right? Okay.
Yes, sir.
So what happens in secondary osteochondromatosis?
They can be secondary to some degenerative changes.
Right. So are you seeing any degenerative changes there?
Yes, it's in the acromioclavicular joint. I can see some abnormality, and also around the glenoid, around the glenoid bone. Inferiorly, there is fuzzy margins of the bony glenoid.
Okay. For the time being, if I take all these calcified bodies out, if you look at this shoulder X-ray, would you say it's normal or not? It's the leading question.
It appears to be normal.
Yeah. So, I mean, that's one thing. I think when you see the joint to be normal, like you said, there is no kind of degenerative changes in the joint, right? So then these bodies are primarily kind of, they are just, I mean, synovial osteochondromatosis is a synovial metaplastic disorder, isn't it? So that's primary. Okay, let me show you the MR.
Well, so here I can see the similar hypointense rounded opacity, rounded lesions surrounding the humeral head, or they are of uniform size. And
that's fine. But I mean, I want you to tell me where exactly these are. What is this structure they are in?
They are in the subdeltoid bursa.
Excellent, excellent. So yeah, they are in the subdeltoid bursa, right? Okay.
Yeah.
Subdeltoid bursa, as you can see, it communicates with the subacromial.
Subdeltoid bursa. Yeah.
Right. So whatever you were seeing on the X-ray, they were primarily in the subacromial subdeltoid bursa. But in addition, if we go to the joint, let me put the axial up. So it's an important kind of distinction to make, that where they are, right? Fair enough. Let me just go back to this one. I mean, the thing is, if it was in the glenohumeral joint, it would have been here, right? Okay. Or this is the articulation. That's the shoulder joint. So all these synovial kind of these osteochondral bodies, they are in the subacromial subdeltoid bursa, right? Okay.
Yes, sir.
Okay. This is X-ray shoulder, frontal projection, right shoulder joint. There is reduced bone density is noted. And I can appreciate that there is irregularity is noted at the lateral aspect of the head of the humerus with some sclerosis. Visualized joint space, glenohumeral joint space appears unremarkable to me. And okay, so it appears slightly reduced. Glenohumeral joint space appears slightly reduced. Rest of the
yeah, that space is okay. Don't worry about that. The space is fine.
okay. Okay, so there is irregularity at the lateral aspect of the head of humerus with okay contour deformity, and there is an sir. I'm suspecting an there is a growth, bony outgrowth that is continuous with the hair, that its cortex appears continuous with the cortex of the bone.
Right, okay, let me magnify it for you, right? Okay, now I'm going to window it a bit for you. Right, okay. Describe it now. I think you can probably see it. You can see it better
okay,
now.
there is erosion is noted at the lateral aspect of the head. Erosion and contour deformity, and there is a retracted portion of the cortex is seen, noted superior to it. So, sir, otherwise the joint spaces are normal. So, considering this, I am suspecting this to be tear, avulsion.
Avulsion what?
Okay. Avulsion of, sir, this is, sir.
Okay, let me show you the other view. Probably that might help, right? Okay, so let me magnify it now. All of you. All right, okay. So where do you see that well-corticated fragment, let's say?
Okay, so that the fragment that was previously seen was apart from the scapula. So,
right. Okay. Let's go back to that. Right. Okay. So all of you can see that this is a well-corticated bone fragment. Yeah.
Yes.
This is not calcification, not the calcification we see normally in the supraspinatus or the rotator cuff tendons, right? Because that will be more. I'll show you that few cases of that, but this is the main thing is the location is probably similar, but it's just the shape of it and the morphology of it is more like a bone fragment, right? Okay. And yes. Now you said like we can see it here. It's projected next to the lateral aspect of the humeral head. All right, and there is a defect here. Okay, so the chances are it would have come from here. Okay, so now you go back to this. Whereabouts can you see that? So this is your coracoid. As you know, always look at the coracoid. So that's your front. So where is the fragment here, Dr. Mavish?
Sir, it is on the fragment that was appreciated is on the lateral aspect here also, and beneath the acromion.
Exactly. So this is that's what you mean, yeah?
Yeah.
So you see, so this is the fragment, or probably a few fragments there. Okay. Right. So this is your subacromial space, the one we have seen on the last case as well, right? So can you tell me which tendon is there which occupies the back half? Like if you divide the subacromial space into anterior half, like this is the anterior half, this is the posterior half. So which tendon lives in the posterior half of the subacromial space?
So supraspinatus?
Well, supraspinatus is in the anterior half. Okay, well, the infraspinatus, if you got supraspinatus in the anterior half, infraspinatus is in the posterior half, right? The subscapularis is on the front. Okay. So this one is, by looking at it, you know that this is in the region of infraspinatus tendon, okay? So what we are seeing now is, let's go back. So you have got an avulsion fracture fragment, which has probably come from here. That's the defect, which looks like an erosion. Okay? And most likely it is because of the infraspinatus tendon that has pulled it away. All right, let's go to the MR now.
There is a bone contusion or bone edema is noted.
Okay, excellent. So we'll come to the bone in a second, but what else do you see there? Is there something not right? Be continuous, not continuous.
So fluid joint effusion is noted, and a tendon I can see that is retracted, and
so this is the tendon. If you look at there, this is your glenoid, right? This is your scapular spine, and above it is your supraspinatus. Below it is your infraspinatus, right? Okay.
Yes.
So this is the supraspinatus muscle. That's the tendon, and you can see that instead of it going all the way attaching to the tuberosity, it's kind of it just stops there. So this is how a complete, how full thickness, let's say, tear looks like, right? So you've got I would say complete tear because it has retracted this much. So this should be there, right? Okay, so there is a complete tear of supraspinatus, right? But we are more interested in the infraspinatus. So let's look at the sagittal now. Okay. So again, coracoid, identify the coracoid. Okay. This is your subscapularis tendon, which lies at the front. Okay. Like you said, there is a fusion. That's your glenoid we are seeing. Okay. This one is your supraspinatus. And the infraspinatus is this muscle here, this big muscle, this one, right? Okay. So let's just see the supra first. So that's your supra, that's the tendon. And as you come further, there you go. You got a big defect there, right? So there's no supraspinatus tendon at all. So this is a complete supraspinatus tear. And if we go back to the infraspinatus now, this is your infraspinatus, all right? You come. There is something here, which we'll look on the non-fat suppressor in a second. And as you come here, there's all this edema. Let me show you the T1. I think it will be, or probably SAG PD will be better. SAG T1. We go to SAG T1. SAG T1 will be even better. Right. So now, it's projecting not very nicely, but it just, you have to believe me now. This is the fragment there, which is this one. You see this. You see, it looks like the same marrow as the humerus, right? So these are the fragments 1 and 2, which are attached to the infraspinatus, and they have been pulled off. And the reason we know that is because there's all this edema here. This is the area which we are seeing as an erosion. Let me put the PD to make it a bit more clearer. So now you can see that's your supra, this is your subscap, this is your infra, right? So let's look at the infra. There's infra, there's the infra tendon there. Okay, keep coming. And there you see, that's one chip, that's the other chip. And this has come off from here, this area. Okay. Yeah, I mean, well, technically you can say that this is a complete full thickness tear can be focal, right? But the whole tendon is gone. So this is a complete tear of the supraspinatus with an avulsion fracture. And essentially, I mean, that's a tear as well, because that tendon has just pulled that bone off, right? Okay. But the way you will describe it as, like you said, it's a complete tear of supraspinatus with an avulsion fracture attached to the detached infraspinatus tendon. All right. And on ultrasound, when I was scanning, I saw this. And this does not look like the kind of that lobular gallstone-like calcification. It looks like a cortical fragment with a defect. All right. So that's why, again, I mean, this particularly here, this looks like a corticated fragment. This is not calcification. So then we did NMR to confirm, and that's what we found. Okay. All right. Okay. You're welcome. Chronic shoulder pain.
Yes. This is a frontal projection of X-ray right shoulder. Glenohumeral joint is unremarkable. Humeral head is fine. Bones are okay. I can see 2 calcific densities in the muscle of in the muscular compartment on the medial aspect, and these densities are well defined. They are well defined, but with fuzzy outline, and a surrounding minimal edema is also noted.
You mean soft tissue swelling? Yeah.
Yes.
Okay.
Halo around.
So you think this is not in the joint, this is in the muscle?
This is in the muscular compartment. This adjacent bone cortex is intact. I can't see any lytic or sclerotic lesion in the visualized humerus. Clavicle is also fine, and rest of the joint, and the muscle compartment surrounding shows no any other lesion.
Okay, so what will be the next thing you'll ask for? What should I show you?
Next, another view can be seen by the.
There we go. That's the other view.
This is axial view.
It's a scapular Y view. Yeah.
Scapular Y view. Yes. Again, the calcific density is noted. One is in the muscular compartment. Another is superimposed on the humerus medullary cavity and the medulla of the humerus. Medulla is there, but however, there is no scalloping of the medullary cavity nor expansion.
Right. Okay. So, what's your differential diagnosis then?
Maybe due to post-traumatic small hematomas calcified, or lipomas calcified.
Right. Have you ever seen these kind of calcifications in lipomas?
Least likely, sir.
Right. What other calcified abnormalities you commonly see?
Granulomatous granulomas are also calcified, but this is
a very odd location, isn't it?
Yes.
Okay. What else?
There is.
What did you say on the X-ray? You said it's in the muscle plane, right?
Yes. Again, it is in the muscle. In the head muscle.
I want you to say that. I want you to say that. Where is it?
Yes.
Is it in
the lesion is noted in the deltoid muscles.
Right. And how would you describe the shape of this lesion?
It is rounded shape.
Or lobular. You can say lobular.
Yes,
yeah?
lobular.
Or lobulated, let's say. Yeah. And this is a fat-suppressed non-contrast study. So what are you seeing? This is a fluid-sensitive sequence, isn't it? So this is hyper-intense, right?
Hyper-intense.
Okay. Okay, good. Right. What about these areas there then? What are these abnormalities in that? Sorry? Low signals, yes. Yeah. What are these low signal abnormalities then?
Low signals are calcified or hemocytic.
Excellent. Good. All right. Okay. Let me go to the T1 then. Okay. Let's look at the plain T1 now, because we can distinguish blood products in T1, can't we? Right. Okay. So this is a T1 weighted image now, right? Okay. So this is, you can see, all you can see, it is within the deltoid muscle, right? That's a deltoid. It's an intramuscular lobulated lesion. And now let's look at the T1 weighted. And what about this structure there? If you go to the bottom like that, no, sorry, let me go to the bottom. And for instance, if we go to this area, let's go to that small thing. Because we saw them to be rounded, isn't it?
Yes, hyperintense on T2.
Well, hypointense on T2. This is T1.
Yes.
This is plain T1. All right. So any ideas what this could be? Or you want to see a post-contrast?
Post-contrast will define it.
What you think about this?
Level.
Level, exactly. So there is fluid level. All of you can see that? There is a fluid level, right? What does that mean?
Cyst.
No, it means intracystic hemorrhage, like hemorrhage, blood products of different ages, right?
Yes, various ages.
And there as well, there is this kind of a fluid level. All right. So can you think about any lobular lesion that contains fluid, most likely blood, with all these heterogeneous kind of foci inside, including those calcified things, which if I tell you these are phleboliths. So this is probably phlebolith. Hemangioma. Okay. Okay, one thing that you need to learn today is we don't use the term hemangiomas for anything which is like this in the musculoskeletal system. This is a venous malformation. Venous malformation, right? These are dilated kind of venous lakes, and these are all what we are seeing. These are thrombi and phleboliths, all right? Okay. And this is not, don't use the term hemangioma. Hemangioma is a cellular infiltrative tumor in musculoskeletal system. I know we see hemangiomas in the spine, we see it in the liver, in the spleen. I mean, we see hemangiomas, I mean, in solid organs, whatever, but, or even in, or in the bone as well. But this is in the muscle when you see something which is lobular. And the other thing you notice here is it's such a big lesion, but there is not much edema around it, isn't it? It's a silent lesion. It's not an angry looking lesion, isn't it? Yeah. So this is basically a venous malformation. Okay. And let me show you the post contrast before we move on. This is the post contrast now. I mean, it has got some filling. I mean, it's not kind of, it hasn't got much. I mean, now that's again tricky with these ones because you can misconstrue that these are enhancement, but I'm going to put the pre-contrast T1 fat suppressed is on your right, okay? And this one is on your left. So, I mean, you can imagine probably that this is enhancing, but this is not enhancement, this is just filling, okay? And how would we know that this is filling? Is there any other imaging modality that we can use to diagnose these venous malformations, Dr. Aslam?
Yes, sir. In other areas, per AVM, we go for the angiograms, digital subtraction, MR, RCT.
I'm talking about non-invasive. Talking about non-invasive.
Non-invasive ultrasound.
Excellent. Ultrasound, exactly. So ultrasound is key in diagnosing these, right? Because in the venous malformation, there'll be all just kind of a cystic kind of thing, and there will be probably some venous flow in it, all right? So to differentiate between a high flow and a low flow, or a lymphatic malformation, we use ultrasound, right? And when you do ultrasound, which I don't have for this guy, this lesion will have kind of spaces with just venous flow, or probably sometimes no flow at all, right? Vascular malformation, so the blood stagnates and it clots. So these are all clots basically, all right? Or like we see in endometrioma or any hemorrhagic kind of cyst, we see these kind of altered like methemoglobin or like old blood basically. All right, okay. So let me show you the X-ray again so that you remember whenever you see any round kind of calcification in soft tissue, you think about granulomas, think about foreign bodies, think about cysticercosis and all those things. But don't forget that round bodies can be phleboliths. And I was very pleased. I mean, you did it very well that on the first kind of image, you said it is not in the joint because the joint will finish here. The joint will finish here, right? That should be the capsular attachment. So it's distal to that. So these calcifications, whenever you see it right next to the joint, make sure that you try to imagine which structure they could be in. Now, this one you said is in the muscle, and now we have proven it's in the muscle. So in the muscle, when you see round bodies, round calcifications, think about, could these be phlebolyths, i.e. a venous malformation? Okay?
Yes, if these can enlarge in size, then what will be, sir, the next management line?
Well, the next management will be, it needs to be, like you said, it needs an angiogram just to see which is the feeding vessel or draining vein, let's say.
Can go for
and then they can do percutaneous sclerotherapy.
Yes, sir.
All right. Okay.
Thank you, sir.
Thank you.
I think what I can appreciate to now is that it seems to me dislocated posteriorly. Apart from that, acromioclavicular joint is normal. If one now I'm
What about the humeral head?
Inferior margin
Yeah, please carry on.
the inferior margin of glenoid is a bit irregular.
Inferior margin of glenoid. I mean, that will be more. You'll be more interested here if the humerus is sitting under the coracoid, isn't it? I mean, this inferior margin. I think this is fine, but you will assess it more if it's an anterior dislocation, right?
Yes, definitely. But
this is a posterior dislocation, right? Okay. So
yes,
now all of us, if we just kind of follow the posterior margin of the glenoid, let's see what we find. That's the posterior margin. That's the posterior margin. What's happening here?
Is there I'm not sure, is this a trough sign?
Okay, trough sign of what? What does that indicate?
A reverse hillside.
Yes, excellent, excellent. So that's a reverse Hill-Sachs, right? So if you imagine, I mean, the center of the humeral head is off, the humeral head is gone back. There's this big indentation of the humeral head. You see a flat line. It should be, I mean, if it was completely off, you shouldn't see that line. All of you can see that line. Yeah. I want you to keep this image. I mean, I don't know whether you guys have seen it before. I've seen it probably 3 times in my last 12 years, like on X-ray, right? This thing there, okay? So what we are seeing here is posterior dislocation with a large impacted anterior Hill-Sachs, right? Okay, now let me go back to the CT now, just to highlight that. So you see? So that's what we were seeing, right? So the humeral head has gone back and there's this big anterior Hill-Sachs, which we were seeing as an indentation. Okay, let me put the sagittal up for you. The sagittal is not that great here, but anyways, it's not typical light bulb. Light bulb, the thing is, that's a described kind of morphology, but it doesn't have to be in every, again, you look at this view, this is a bit oblique view. It's like a semi-scapular Y and a coronal. It's a mixture of both. But the thing you notice there is that you are seeing the whole glenoid looking at you. The humeral head should be sitting on it, right?
Yes.
Off center, it's gone back, and then you see that there is this flat line, straight line. This is anterior Hill-Sachs. So this is an impacted, engaged. I mean, this will be very difficult to reduce because the thing is, I think this patient would need GA or probably sometimes they need open kind of reduction because this, if you look at this, look at that.
Yeah, it's being impacted over there.
Yeah, it's just the edge of the glenoid. Sorry, just there. You see, this sharp thing is just kind of indented, and then if you come down, there is something else, a tiny fleck, which you can call this one. You see? You see that?
Yes.
So this is, if you see it at the front, you will call it an Alpsa lesion, which is an anterior labral periosteal sleeve avulsion kind of thing. This is a palpsa because it's posterior. But anyways, that's by the by, right? But this is, just remember that morphology. That's how a posterior dislocation with a large anterior Hill-Sachs looks like on CT and the X-ray. All right?
Okay.
So this is a 15-year-old girl and she's got back pain.
Okay. There is a mixed sclerotic lytic lesion involving the left iliac blade and
where about the iliac blade is it? I mean, the iliac blade is quite a big area, right? So you think it's anterior or posterior?
Close to the ala of the sacrum. And
All right, the ilium of the sacrum is here. So this area which kind of borders with the sacrum is called the posterior ilium, right? Okay, so that's what we're referring to, aren't we?
yes, sir.
There is this heterogeneous, sclerotic, and lucent abnormality of the posterior left ilium, right? Okay. What's happening to the SI joint? Can you see the SI joint there?
So there is also some radiolucency or is involving the ala of the left ala of the sacrum, and there is some.
I want you to compare this sacroiliac joint space.
So there seems to be some erosion of the left.
Erosion, or you can say a bit of widening. Yeah. Okay.
Yes, there is widening. Yes.
Okay. Right. So, what do you think is happening? What's the diagnosis? What's the differential diagnosis we have?
So this is a mixed lytic sclerotic area, and some cortical break is also noted. No.
Cortical break, you mean here?
Yes, sir.
Well, I mean, that's that area we have described. So, I mean, don't go there again. But what's the important thing that we need to try to assess when we see abnormality on one side of the joint? Is there any abnormality of the sacrum?
Sir, I'm not sure. I don't think so. There is any.
Yeah, okay, fair enough. You're not sure, but it doesn't look like it's a bit dissimilar, isn't it? The main abnormality is on the iliac side of the of the left sacroiliac joint. Yeah.
Yes, sir.
All right. So, any differential? Anything you
Sir,
can?
Sir, I'm thinking if the patient is 15 years old.
Yeah.
So I'm thinking on the line of it's involving on one side of the joint. So I'm thinking about any neoplastic lesion.
Okay.
It can
Right.
be
Like.
it
Okay,
can be
can-
and it's other differential regarding neoplastic lesion. In this age group, it can be leukemia. But
Okay, so neoplastic is one. Neoplastic is one. What other process can give you appearance? So whenever you look at bone kind of process, bone abnormality, you think about neoplastic. Yes. What else?
So it can be infective.
Yeah. Okay. Good. Yeah, it can be infected. Yeah. Okay.
And sir, and it can be eosinophilic granuloma. But
Well, that again, you're going towards neoplastic lesion, isn't it?
yes, sir.
Okay. So the primary thing you were thinking, either this is infection, or the first thing you think is it's a neoplastic process like Ewing's, all right? Or the second is infection. Okay. Could it be inflammatory? Could it be sacroiliitis? She's 15.
Yes, it can be.
But again, it's not a typical appearance, isn't it? Yeah. Okay. It's a bit asymmetric. There's not much happening in the second. The only thing is the SI joint is a bit widened, right? Okay.
Yes.
Right. So okay. So the patient was in severe pain. So we did an MR. Okay. So if I stop there, probably there, let's say, let me stop there for you. What do you see there?
There hyperintense signal intensity is noted.
Where about?
Sir,
In the bone?
say in that left ilium, and but other bones they also show hyperintense signal in them. So right ilium.
Yeah, even the femora, you're seeing these kind of bright spots, aren't you? But that's why. Okay, but let's just describe what we see centered in around the left SI joint. There, I think that probably is as better as it gets. Yeah. Okay. So So just describe what you see there, ignoring whatever else is happening in the pelvis. We'll come to that in a second.
So there is hyperintense signal intensity is noted in the left ilium, and there is also hyperintense signal intensity is noted in the left gluteus maximus muscle.
Yeah, okay. And what else? You got fluid joint.
Vision noted.
And what is this?
Intermediate signal intensity area with high signal intensity.
So what's it doing to the muscle? What's it doing to the muscle at the front? It's displacing it, isn't it?
Displacing it anteriorly, sir.
Yeah. So what is this then? You got marrow abnormality. You got extensive fluid signal in the gluteus maximus muscle. But what is this lobular abnormality next to the joint? What is that? What's the term you use to describe this?
Geode.
Sorry?
So it can be it's a geode or.
Geode is in the bone. Geode is like a subchondral cyst.
Sir, you said that next to joint, then I just immediately jumped.
Yeah. So it is next to the joint.
Yes, sir. This is.
What was the first diagnosis that you told me it could be?
The Ewing's.
Yeah. Okay. Have you seen Ewing's in this place?
Sir,
Okay. What does Ewing's look like? I mean, what's the typical appearance of Ewing's? You got a medullary. You got a bone base like a marrow abnormality, but there is this extension of the tumor outside. Large extraosseous soft tissue. T1.
Changes in the whole of the skeleton, almost whole of the visualized bones.
So what are these round kind of multifocal lesions there?
So it can be METs.
These are metastases. These can be not. These are METs, right? You see these round lesions, they're everywhere, right? And then you come here. This is the big mass sitting there, which we were seeing. And this is all tumor in the posterior ilium. Okay, with probable infiltration in the gluteus maximus as well. Let's just show you the post-contrast. So always, you were right. I mean, you approach it very nicely, but it just on MR, you see, that's the post-contrast. A bit of enhancement there. This is an extraosseous soft tissue mass. This is a necrotic kind of area, necrotic mass in the ilium. And then that's the one which is extending into the gluteus maximus. This could be TB, that's the other thing, but TB would seldom give you this kind of a large lobular soft tissue mass. But in that age group, I mean, you have to think about Ewing's or TB. These are the two things. And it was biopsied and it came back as Ewing's. All right?
Yes, sir.
Okay. So what's the next step? If you diagnose it comes as Ewing's, how will you proceed then?
So next, there must be some histological correlation, and then the staging CT chest. Sir, CT brain, because
CT brain? Why CT brain?
No, sir. Actually, I was confusing it.
But you can't CT brain every child who's got Ewing's.
CT chest, sir.
Yeah, CT chest is good, but how would you distance stage them? Have they got any other lesion in other parts of the skeleton?
It's a bone scan.
Bone scan bone scan used to be done and probably still being done, but it carries a lot of radiation. So what's the other thing that you can do which doesn't carry any radiation? You can do whole body MR. You can just do coronal T1 and coronal star. So most of the tumor centers across the world, they are moving towards doing whole body MR. Or in some centers, they do even PET-CT, which carries radiation. But I think the general kind of consensus is that you do whole body MR if you see Ewing's or osteosarcoma or any aggressive bone tumor. All right?
Yes.
Okay, good, excellent.